Hello and welcome to the Myositis Association's Ask the Doc webinar series. My name is Rachel Bromley and I am TMA Senior Manager of Patient Education, Support, and Advocacy. Today we have the honor of speaking with Dr. Merrilee Needham. Dr. Needham is the current Foundation Chair in Neurology, a joint position between Fiona Stanley Hospital, Murdoch University, and Notre Dame University, Australia. She is a consultant neurologist at Fiona Stanley Hospital, the Director of Research for the South Metropolitan Health Service, and the Group Leader, Myositis Discovery Program, Center for Molecular Medicine and Innovative Therapeutics, Institute of Immunology and Infectious Diseases, Murdoch University. She is also a board member of multiple organizations and the recipient of many awards, all of which you saw in the bio for the advertisement. Thank you so much for being here, Dr. Needham.
Thank you for inviting me. It's great to be here.
All right. Let's get started on our questions. We had several submitted through email. First, let's talk about the Australian clinical IBM trial results.
Well, we're running two trials here in Australia at the moment. We have an investigator-led sirolimus trial that's actually a global trial. So there's a couple of US sites just about to start at Hopkins and with Professor Demarchke. So this one is really a larger trial of the phase sort of 2B done by Olivier Benveniste in Paris. Because the trial's really only commenced in Australia, our longest patient's only been on it for 6 months so far out of about an 18-20 month treatment period. We don't have any results at all at the moment. So all I can tell you is that we're enrolling, patients are keen, doing, tolerating the drug, but I can't tell you anything about results because we just don't have any yet. It's just too early. The second trial that we have running is a pharmaceutical company from America, the Abcuro study, which is an anti-KLRG1 monoclonal antibody. And that was a phase 1 study that we've been running. So really, it's not about efficacy against disease. Phase 1 studies are entirely about safety. So this is a first in human study for this drug. And again, very small number of patients because we're just testing the safety of the drug. So I think the company did release some preliminary results in poster form recently at the American Rheumatology Association meeting. But again, no publications have been published yet with results on that yet. So that's as for coenzyme Q10. That was in the same question. I haven't seen a study on coenzyme Q10 and I haven't done a study myself. Some of my patients elect to take it to try to improve their endurance because it helps mitochondrial function. And I usually tell my patients to try it for 6 to 8 weeks at a dose of 150 milligrams twice a day. And if they don't notice any benefits with regards to endurance, then I tell them to stop it because it's quite expensive to continue on it if it's not providing any benefit. So that's all I can really tell you about those.
Okay. And our next question is about IVIG. Can it be stopped abruptly without titrating the dose or increasing the time frame between infusions? How do providers know when to stop this medication?
That's a great question. So we use IVIG in a lot of autoimmune diseases, predominantly those that we think are antibody-mediated diseases, because we think that's how it works in terms of modulating the antibody aspects of autoimmunity. Yes, you can stop it abruptly. You don't need to wean off it. That being said, if I've got a patient that has definitely responded to IVIG, but between infusions, they're not getting a wearing off effect before the next infusion, sometimes to check that they don't really need it on an ongoing maintenance, that the other drugs that they're on, the mycophenolate or methotrexate, are controlling the disease, I do often reduce the dose or extend the interval to check that the patient doesn't then start to get relapses of symptoms. And that's really how we know to stop. So we just, there's no, unfortunately, scientific way to know when to stop. If patients are clinically and biochemically in remission, then we try to maintain patients in remission on the lowest effective dose of immunosuppression. So because IVIG is quite an intensive medication to be on, you have to go in and have infusions every, 4 weeks often, sometimes for 2 days every 4 weeks. it's a real impact on lifestyle if you want to go traveling and do other things. And so it's one of the first ones I do try to get patients off, and I try to manage patients on oral medications, often, very low dose prednisolone and a steroid sparer like mycophenolate or methotrexate. So I often use IVIG to help get rapid remission. And then I try, when patients are completely biochemically, as in their CKs back to normal, and clinically, like their strength is back to pretty close to normal, or as good as we think we're going to get it, then I try to stretch out the interval and reduce the dose and check patients don't relapse either with a bumping up in the CK or getting weaker again, and then I'll stop it. But yes, you can safely stop it suddenly if you're doing really, really well and your clinician's confident with you that you're in remission, or if you're not tolerating it. If you're having allergic reactions, you can stop it suddenly. You don't need to wean it.
I wanted to say, if you have a question for Dr. Needham, you can put it in the Q&A and we will ask it as they come in. In your bio, it mentions World Muscle Society. Somebody picked up on that and asked, what is World Muscle Society, and can these groups help with patients like me with myositis and MCTD and cardiovascular neurological issues?
So there's lots of groups of around the world of people interested in muscle diseases, and World Muscle Society is one of those. So it was initially probably started more around the genetic muscle diseases, but it does encompass all muscle diseases. So myositis is definitely does feature. They have a biannual conference, the World Muscle Society Conference. So that's an international, it might even be an annual conference, actually, I think in October usually. And they also have a journal, neuromuscular disorders, associated with this group. And it's really just a collection of specialists, clinicians, patients, allied health who are interested in muscle diseases and talking about all aspects of that, from diagnosis to treatment to monitoring disease to establishing clinical trials. So it's another group, I guess, like IMyos, which is focused on myositis. This is just a broader group focused on muscle disease in its entirety.
Someone wrote in, do you ever try steroids with IBM patients, and under what circumstances if you do try them?
That's a great question. And the answer to that is very rarely, because the toxicity of steroids is quite high. So there's a very few patients, but there are a few. And I guess they're my younger patients who are who have a very inflammatory biopsy and higher CKs. And earlier in the disease course, I tend to try them sometimes on steroids because there's this group of IBMers that sort of start more like a polymyositis, but still have the distribution of weakness of IBM, who do seem to respond for a period of time, perhaps on immunosuppression. That's controversial and certainly not proven in the literature. It's just an observation that a few of us have made. But over time, I have to say that immunosuppressive effect wears off and it becomes degenerative. So it's not a forever thing in IBM. So occasionally, to try to get an improvement in strength, I don't really worry too much about the CK in IBM. I don't think it really reflects what's happening in the patient in IBM terribly well. Occasionally I'll try it, but patients have to really know what they're signing up for, because the side effects of steroids are pretty high and there's no evidence for efficacy. So in medicine, if I'm prescribing a drug to a patient, it's always potential risk to the patient versus the potential benefit. And we can't promise any potential benefit in IBM. There just isn't the evidence that it really makes a difference, particularly to long-term outcomes. And there are significant risks. It causes high blood pressure, high sugars over long periods of time, cataracts, osteoporosis. So it's a drug with a lot of side effects and a lot of risk attached, and probably not a lot of real benefit. But there are some patients that really want to try it just in case they're poly and not IBM. And if there's ever doubt in my mind, I might propose a 6-month trial where we do a reasonable course of steroids, but I have very strict physical measures to check that they're not just feeling better, because prednisolone sometimes will make the aches and pains go away and make you feel a bit better. But actually that their muscles are actually getting stronger. And I always combine it with an exercise program. And if they're not objectively responding, then over the long term, the risks of steroids, if they're not getting the benefit, are just too high and we wean them off.
How much is considered high CK for IBM?
So we say in the diagnostic criteria, it should be less than 14 times the upper level of normal for that individual. And that depends a bit on your age and race and gender. So I guess high in IBM is, usually over about 1,000. In IBM, it's often in the hundreds or even normal.
Okay. We have someone that is tuning in from Atherton Tablelands in Queensland. This person has dermatomyositis and have flared for the first time in 5 years. Do you have any idea what the main causes of flares are?
Well, DM is often a relapsing, remitting autoimmune disease, and anything that makes your immune system, if it's active at a low level and we're keeping it under control with medications, anything that makes your immune system active, if you have an auto-reactive part of your immune system, it will rise with the rest of the immune system. So infections can cause your immune system to rise, sometimes vaccinations, sometimes in Australia, hay fever. So around springtime, we often see a bit of a flare with DM, perhaps because of the allergens around in spring. And sometimes we don't know, sometimes even, there are other reasons why your body's immune system becomes a little bit perturbed. We can't always identify a reason for the flare. In DM, sometimes I look for underlying cancer if I can't find an explanation, depending on what type of DM. But 5 years would be unusual for that. But that's something to maybe consider as well. So yeah, we can't always answer that question as to why you flared. Sometimes we can't identify that.
Mm-hmm. Someone asks, is there any treatment you would consider or recommend for IBM? Do neurologists differ from rheumatologists in their approach to IBM, and what may be the cause?
Empirically, I think rheumatologists do differ a little bit from neurologists in their approach to IBM, because rheumatologists are used to treating people with immunosuppression for autoimmune disease, and I think they struggle not treating patients with autoimmune disease with immunosuppression. So I do notice a bit of a practice difference, whereas neurologists are very used to having diseases we can't treat. So I think there are differences perhaps in that regard. I think more often IBM does come to neurologists because it's a less acute presentation. So you often end up at neurologists, and I don't think that's necessarily a bad thing to not be treated at the moment with the level of evidence we have for traditional immunosuppression. I do think IBM is quite unique, and I think we need cleverer therapies, and that's why we're trialing different forms of immunosuppression in IBM compared to other forms of myositis at the moment. So watch this space. I think it's an exciting one, and I hope that we do have some standards of care and good treatments that everyone around the world will be using in the next few years. As for now, the standard of care in IBM is mainly supportive, and I'm very big on exercise. So with muscles, if you don't use them, you lose them. And so if you're able to exercise, even if it's sitting in a chair, it doesn't have to be out running. It can be chair-based exercise. It can be bed-based exercise. But whatever muscle you've got left, you want to optimize it with a bit of a combination of a little bit of aerobic exercise, but you need some resistance-based exercises in there as well, with lighter weights and more repetitions to really help optimize that muscle function of the muscle you've got left. So it's looking after muscle with exercise. It's looking after your home environment with aids and modifications to make your home life as easy as possible. Psychological input to support your mind, because I think living with disability and chronic disease, especially when it's getting worse over time and threatening independence, has a big impact on your mental health. So I think we need to address that. Always helping your carers understand what's happening in your families by education and support, and then breathing function. So I'm also moderately aggressive with management of dysphagia, nutrition, and breathing and sleep. I think sleep and eating are very important. So I do spend a bit of time with those. So they're the kind of things that my IBM patients go through in our clinic.
You once said exercise is equal to medicine, and you just recently talked a little bit about it. Could you elaborate on it?
Exercise is as good as medicine. So I mean, I think it's an adjunct to medicine, and so we know that exercise itself is anti-inflammatory. So I think it has a direct impact on inflammation for all forms of myositis, but I guess especially for IBM, where we don't actually have a medicine yet that's very effective for the inflammation in IBM. So at the moment, because we don't have a medicine, I think exercise is the mainstay. But when we do get a medicine, that won't diminish the role of exercise. So for all other forms of myositis, I still push all my patients to exercise. So the drugs that we use for myositis are very good at turning off inflammation, but they don't build strength or improve function. Only exercise does those things.
What is your opinion about blood flow restriction therapy?
Yeah, look, we did a trial locally for that and didn't find a significant effect, but other people have. I think it's a very, I think if the evidence seems to suggest it's better than exercise alone, blood flow restricted exercise. That being said, some people find it very uncomfortable and it's a bit impractical for day-to-day use. So I think it perhaps has a role, but I think we haven't worked out exactly what that role looks like in day-to-day practice. I try to get my patients to exercise a minimum of 5 days a week. So unless they can do it themselves, that's often not feasible for patients to be coming in and out for someone else to manage that. So it perhaps has a role, but I don't think we've quite worked out the best formula for adding that into day-to-day exercise at home.
This question is about IVIG. I've heard that some IBM patients have benefited from IVIG, and what are your thoughts on IVIG treatment for IBM patients?
Yeah, I don't know what your rules are in America. In Australia, we're allowed to use IVIG in IBM in only 2 circumstances. One is rapidly progressive disease, and the other one is very severe dysphagia or swallowing problems. And that's because the trials for dysphagia, in particular, the swallowing, suggested that there was perhaps some short-term benefit from IVIG in improving swallowing function. And empirically, I have tried it for that in a few patients where the swallowing's really gone off. And it does seem to hold the swallowing for a period of time, but it is just a short-term thing. It doesn't seem to hold it or improve it forever. So I'm not sure yet if there's a long-term role for IVIG, but sometimes I do use it for shorter-term periods in IBM. If somebody seems to be going off quite quickly for some reason, and they're otherwise looking quite inflammatory with their biopsies, particularly if they're antibody positive or if they've got severe swallowing problems, I might consider it, but it's the vast minority of patients I would try it in.
This person takes IVIG, and after they remove the IV, she shakes uncontrollably for about 2 hours. Have you had a patient that had the same reaction?
I have some patients that do have bad reactions to IVIG. I guess it's hard to know whether that's an allergic response or it's hard to know if there's any rash or if the blood pressure is changing with that. If it's just shaking, I guess you'd want to make sure that that your temperature was okay and that your OBS were okay, your blood pressure and pulse rate. You are taking quite a lot of fluid in with the IVIG that's a little bit thicker than blood, so you need to make sure you're well hydrated. In some of my patients that get side effects from the infusion, I pre-dose sometimes with steroids and antihistamines to try to help prevent those sorts of reactions, and sometimes that helps. If they get headaches, I give them anti-inflammatories like Nurofen, and sometimes that helps. I'm not sure exactly what that shaking is. I haven't seen anything quite like that, I guess. So it might be worth talking with your doctor about that and seeing if even a change of brand will help. So sometimes changing, I don't know what brands you guys have, but we can change from Intragam P to Flebogamma or Privigen. We've got a few different versions of IVIG. So sometimes changing brand helps because sometimes it's the preservant in it. So it definitely would be worth talking to your doctor about those reactions and seeing if there's anything they can try to work with you to eliminate that, because that sounds pretty awful.
What do you recommend for your IBM patients with diagnosed related respiratory failure with respect to ongoing monitoring and interventions? Do most IBMers eventually develop it?
I would say, so I guess to start with the beginning question, the standard of care for respiratory failure due to muscle weakness is non-invasive ventilation, and usually BiPAP rather than CPAP. So that's bi-level ventilation compared to the continuous pressure that we use in obstructive sleep apnea. And particularly my patients use it at nighttime because that's when it really becomes a problem. So with regards to the second part of the question, sleep disordered breathing, I think, is under-recognized and more common than we think in IBM. But going over the cliff into respiratory failure due to muscle weakness only happens in a very few patients with IBM, by far and away not the majority. So a lot of my patients do end up on nocturnal non-invasive ventilation, maybe up to a third, but certainly that doesn't extend into daytime breathing. So I've only had 1 or 2 patients ever have true type 2 respiratory failure due to muscle weakness with IBM. So that's rare, and certainly not inevitable, definitely not.
Anecdotally, somebody wrote in about my doctor's office called me to say that my most recent blood test was negative. So I asked them, negative for what? And she replied, myositis. I haven't spoken to the doctor yet, but I didn't think myositis ever goes away. Can it be cured, or is this a remission? Or
so I guess that's a tricky one. I guess what the doctor's perhaps saying is that the blood test for the myositis specific antibodies was negative, but that doesn't necessarily mean you don't have myositis. It just means you don't have an antibody. So, you would have to go back and probably have a discussion with your doctor. Okay, if I'm antibody negative, but I still have muscle symptoms or muscle disease, what does that mean then? What is the cause of my muscle symptoms or muscle disease? What's the next step? Is it a biopsy? Is it an EMG? But I assume that's what your doctor's saying when they say you're negative for myositis, is just you're negative for the antibodies that we can test for in blood. That doesn't necessarily mean you don't have myositis, and it certainly doesn't give you an answer as to what the cause of your muscle disease or symptoms are. So I think that's the kind of question you want to be asking your doctor.
I was diagnosed with polymyositis in 2009, then changed to IBM in 2014 after a second muscle biopsy. I now use a walker, but my knees are severely hyperextended, causing a lot of pain in them. I've also used AFOs for the last 5 years. My neurologist that's new to me claims he hasn't seen anyone walk like I do who has IBM. His advice was to stop walking or try knee braces, which he suggested are difficult to use. I have done PT in the past, but I'm getting worse. Do you have any opinion on what their doctor said or suggestions for knee braces?
I will tell you that unequivocally, I see this gait all the time in my my IBMers, especially my long ones like you that have had it for 15, 20 years, where the knee actually bends entirely the wrong way. So it's hyperextended and bending backwards when it's straight. So I definitely see that in IBM, and we are actively looking. My physio Ian is very keen to try to find a brace that works, because we can see the trouble it's causing people. I'm not sure that you should stop walking, but finding a brace that works is quite hard. One of my patients has worked with an orthotist that has a brace that has a rim above and below the knee and helps to prevent the hyperextension, and that works really well for him. I've had another patient use just a complete straight leg brace that locks the knee in extension. That obviously makes it really difficult to sit down and go to the toilet and do day-to-day stuff. We've recently looked at an exoskeleton in some of my patients with IBM that allows flexion but then locks it straight. But that's super expensive, that one, and I'm not sure it's going to help all my patients with IBM either. Looking at how it worked. So we're actively looking in this space, but I would encourage you to find a really good orthotist who's curious. The AFOs, when you have hyperextension of the knee, sometimes make the gait worse. So it's a tricky one if you have foot drop and a hyperextended knee. So you need a really good orthotist or some sort of rehab engineer to look at your legs and see if they can work with you to custom design one. And if you find one, do get in touch, because you're not the only patient suffering that. And there's a lot of patients that would benefit from us trying to be clever about this. And as I said, my physio Ian is working really hard with some engineers in Adelaide trying to answer exactly that question. So keep hunting for an answer and share it when you find one.
How often do you see myositis patients who have had intestinal blockages? And what type of diet do you recommend to help your patients avoid blockage?
I guess constipation is not uncommon as you get less mobile. I guess that's more of a problem than true bowel blockages. I haven't seen much bowel obstruction in my myositis patients. Occasionally I'll see GI involvement in my DM patients, but not in my other forms of myositis. I've never seen gastrointestinal involvement in any other forms of myositis, but I definitely see it particularly in NXP2 antibody-associated dermatomyositis. So constipation would be a much probably bigger problem for my patients, particularly those that take opiates for pain, like a bit of morphine or buprenorphine. And then I just try to manage it with diet. So a diet high in fiber, natural fibers, and drinking plenty of water to try to keep things moving along. That's but I'm not sure if I answered that question.
I am still in considerable pain with lots of skin rash with DM, even though my CK levels are normal. Do you see this often in DM patients? My doctors say this pain is not DM, but probably fibromyalgia.
Yeah, look, I think we do. I don't think the CK necessarily reflects pain, and certainly we do see some DM patients with really active skin and even inactive muscles, and vice versa, really active muscles and very inactive skin. So they don't necessarily go together. And pain, I don't think we fully understand where the pain comes from in myositis, but in DM, I think it's much more likely to be a fascial pain rather than a muscle pain. So the CK is not going to be elevated if it's coming from the fascia and stretching. I'm not sure that you would really truly fit into a fibromyalgia definition, because you have the underlying connective tissue disease and fascial disease. So, there are some increasingly good treatments, the JAK inhibitors for the skin in particular, and the new anti-interferon beta therapy that's coming out with Pfizer have very good efficacy for skin disease. So if I were you, I'd go and talk to your doctor. Just because the CK is normal doesn't mean your disease is inactive. So I would, if your skin is very active, that's a sign that your disease is active. And I would be encouraging you to have discussions about more disease-specific therapies like the new JAK inhibitors and the interferon therapies, because you might get a lot of benefit, not just from your skin, but with your pain once you reduce that disease activity down.
This person has NXP2 antibody DM, but by the time they diagnosed the disease, I was already feeling 95% better, but my doctor still thought I should be on steroids and methotrexate. Have you ever had a patient that didn't need any medications with DM?
That's a great question. I think this is a big area that we're all looking at around the world at the moment. This is the flip side of the other question. Just because you have an antibody doesn't necessarily mean you have the disease. And likewise, you can have the disease and not have an antibody that we know of yet. So in this case, I have a few patients like you who are completely well, and I can't even explain why the antibodies got tested. Presumably you were unwell and somebody thought to test it, and then you got spontaneously better. So with those patients, my approach generally is I don't treat blood test results in isolation. I treat the whole patient. So I look very carefully at the patient. If the CK is normal, the muscle strength is normal, their function is normal, their energy levels are good, then I don't treat with immunosuppression at that time, but I do monitor closely because we don't know yet whether, if you have the antibody, that next time your immune system flares, will you then get a flare of disease, and will it come and be more clinically manifest? And then you might need treatment, but that might not be for many years or ever. We just don't know. So I monitor those patients quite carefully, and I work with them and their general practitioners so that they can feel comfortable off treatment but knowing that perhaps they're at risk of developing something down the track. And if they do, then I'm there if they need treatment, and we can get them in a hurry. So I monitor CKs, I monitor, the patient and their skin, and they know what to look out for. And together we work together, not necessarily always on treatment. That being said, I've got a few patients that have an antibody who I'm pretty sure they're weak, but the patient themselves has over time gotten used to a certain level of function, and is comfortable with that function. And that's a different discussion because they almost certainly have active disease. And I project that if we don't treat them, that they will continue to get slowly weaker. And so that's just a really open and frank discussion with that patient, again, about the potential risk of therapies versus the potential benefit. And I think all these decisions are joint decisions. They're not, the doctor is recommending something, but it's a partnership. They should be discussing it with you, and you have to really understand the pros and cons and make decisions with your doctor. If you're completely well and you have an antibody, I agree with you. You may not need therapy, but just check that you don't have disease that you're kind of just gotten used to.
Speaking of CK levels, this person writes in, doctors often say when your CK level is low, but you are still in considerable pain with dermatomyositis, that is not the DM causing the pain. Is that a correlated thing?
I don't know. I don't think that is a correlation. As I was saying to the previous question, I think the pain in DM or in myositis, we don't fully understand. I think that's the first thing. And the second thing, I don't think it just arises from the muscle, which is all the CK is really measuring is muscle breakdown. It's the CK is a reflection of muscle bulk and muscle breakdown. So with DM, it's quite an interesting disease. You can see on MRI, the fascia really lights up, the skin disease. There's lots of structures that are abnormal in DM. And so the pain could be arising from any of those. So I don't think CK is a good marker for pain. And I don't think just because the CK is normal or low and you still have pain doesn't mean it's the DM. Likewise, though, sometimes pain, when you have a disease, it's really easy to think all your symptoms are that disease. So a lot of my myositis patients also have arthritis, for example. So because when you have muscle weakness, particularly in IBM, you can get acceleration of arthritis and degeneration of the joints because the muscles aren't strong enough to protect the joints. So it's worth just exploring whether the pain is your DM, but if it's the same pain you've had and it comes and goes with your disease flares and you're pretty sure it's your DM, then treat it as DM.
What are the latest theories on the cause of IBM?
I think it's still a little controversial, to be honest. For a long time, we wondered what the chicken and the egg is. Is it a primary autoimmune disease with secondary cellular degeneration, or is it actually the other way around? Is it primarily a protein deposition disease, a TDPopathy with secondary inflammation? I think Steve Greenberg wrote a really nice review in 2019 about IBM. And I think probably a lot of people are now agreeing that this is probably primarily an autoimmune disease with chronic low-grade inflammation that ultimately is driving cellular degeneration and mitochondrial changes. So I think probably that's where most of the thought is at the moment, that it's an autoimmune disease mediated by these terminally differentiated CD8 T cells that are otherwise resistant to traditional forms of immunosuppression. And that's why we're trying these new therapies, the anti-KLRG1 antibodies.
There seems to be a lot of controversy regarding the use of statins in IBM patients. What is your opinion?
I think cardiovascular disease is probably overrepresented in IBM, and both are diseases of aging. And there's no evidence that I've ever seen that statins worsen IBM or make the muscle disease itself worse. I think the risk of dying of a heart attack or a stroke in that population is probably far higher than any risk of statin on the actual disease. I've never seen an acceleration of disease. What I do with my IBM patients is when a statin has started, I just monitor both their physical function and CK a little bit more closely for 6 months. If you're going to get a toxic effect on muscle from statins, it's usually when you first started or when you do a dose increase. So I just monitor them a little bit more closely. But I've got over 100 IBM patients, and not once have I ever had to take a patient off statin with IBM because I thought it was worsening their disease. There's a couple of patients that get muscle pain that don't tolerate them, and I switch them to different families of anti-cholesterol drugs, but I don't think that's necessarily it worsening disease. So, and Steve Greenberg did a really nice health economic study in the States, and the incidence of cardiovascular disease seems higher in IBM as in all patients with autoimmune and inflammatory diseases, actually. So, again, it's that potential risk versus potential benefit. If your risk of heart attacks and strokes is significantly higher, then you need to mitigate that risk alongside, watching your IBM.
Have you seen situations where the bladder is impacted by IBM?
That's a great question. Actually, Kelly, who works closely with me, she leads my research program, has recently done a survey because she's a nurse, and she picked up that quite a lot of patients were having bladder and bowel involvement. And I think as a doctor, I probably don't ask about that quite as much as she does. And so she and a medical student, Jen, recently drove a survey across Australian myositis patients to look at bladder involvement. And found a very high incidence actually of urinary incontinence in our myositis patients. So we're further exploring that. We don't know if it's a direct effect of the IBM on either the sphincter or the bladder, or if it's simply that people can't get to the toilet as easily, but we think it's more than that actually from our initial data. So I think it's under-recognized, and watch this space because Kelly's going to publish it soon, I think.
That's good. Is there any connection of ganglion cysts with IBM?
Not as far as I know. Ganglion cysts, though, I think are associated with underlying arthritis. So I guess if you've got I think IBM patients often do get accelerated arthritis due to the muscle weakness. So maybe there is with that, but that's not something I've ever seen or read about. Sorry, you're hearing the kookaburras laughing in the background.
Do you ever see ILD and IBM coexisting?
Never.
Good.
No, if you had ILD, I'd be looking either for two diseases or something else, some other form of myositis.
Okay. My father had IBM, and now I've been diagnosed with IBM, but they say it's not a hereditary version, that it's sporadic. How is that?
That's really rare. I have a mother and son that I think both have IBM, but it's extremely rare. We know there's genetic predisposition, particularly with the HLA group, but it's probably, I suspect there's a few genetic susceptibilities. Perhaps you need a genetic susceptibility in your protein breakdown pathways as well as your immune system pathways to get IBM. So we occasionally see it in siblings who potentially, I guess, inherit the same gene combination from their parents with regards to those, but very rarely. In fact, you're the second case I've ever heard of with a vertical transmission from parent to child. And in our case, the mother and son had different HLAs, so it was pretty unlucky. We've looked really hard for monogenetic causes of IBM. So Pedro Mercado drove quite a large whole genome and whole exome sequencing study in the UK that's still ongoing, I think, but the whole exome we couldn't find a single gene that seems to run through families. There was some gene associations with some genes like VCP that do cause inherited forms of inclusion body myopathy, which is a bit different from inclusion body myositis. So I guess it would be interesting to maybe talk to your doctor about whether it's worth doing a genetic screen with a neuromuscular panel to see if you had one of those rarer ones that Pedro did pick up. But that's very rare. We've hunted for a single gene and we don't think it is the case, but maybe you and your parent had the same gene combination, but unlucky.
It sounds as though both current IBM drug trials are in the beginning stages. Realistically, what is the timeline for determining whether or not the two drugs are useful and then would be available for patient use? Is there anything else being talked about that is being explored?
That's a great question. Realistically, we have to wait for the trials to finish and then the data to be analyzed before we know whether the drugs are going to be effective. So for sirolimus, our timelines that the trial should finish within a couple of years, and hopefully the data analysis the year after that, so 3 years. The ABCURO study is probably pretty similar with initial results. Because the Abcuro drug is a brand new drug, it has to go through a whole lot of licensing stuff. So the timelines to then be available for widespread use is probably years after that. I'm not sure how many. IBM has orphan disease status, I think, with the FDA, so it may fast track in America. Sirolimus is already available across the world, so that was one of the reasons we wanted to try it. So I think if we can prove that it's safe and slows progression of disease, let me be clear, it's not a cure. It's not going to make you better. What we're looking for with sirolimus is to stop progression. So if we can halt people's disease or slow the progression down, which most of my patients say would be a good win initially while we wait for a cure, then there's no reason that your doctor couldn't prescribe it once the evidence is published. So that's kind of the plan, is that hopefully, hospitals and insurance companies and stuff, once we've got the evidence out there, will fund it.
Are there serious side effects with sirolimus?
Sirolimus is an immunosuppressant. So like all immunosuppressants, there are potential serious side effects. So it does suppress parts of your immune system down. So there's always a slight risk of infection. The main side effects that we're seeing are leg swelling and mouth ulcers and gastrointestinal side effects, none of which have been serious yet. And that's what Olivier Benveniste reported in his study also. But definitely there are some rare side effects with regards to kidneys and lungs that we're watching out for. So I think, like all drugs, it's not completely risk-free. And your clinician would just work with you to monitor you closely for those. And it's, again, weighing up the potential risks. So not everyone gets side effects, and not everyone, hardly anyone, hopefully gets the serious ones, but against the potential benefit, and you weighing that up in your own, I guess, context about whether you're prepared to take those potential risks to get the potential benefit. Yeah.
Has anyone done a study to look at environmental or even situational elements that create conditions for people to get IBM?
Yeah, so we are actively looking for that, but proving causation rather than just association is really difficult, particularly in retrospect. So because IBM is such a slowly progressive disease, it probably actually starts a good 8 to 10 years before we see people in clinical practice. And trying to get people to remember some of their environmental exposures from even decades before that, and track those over time, and then proving that it actually caused IBM is another whole separate question. So the first question is looking for associations, and we're doing that through patient registries. I would suggest all of you, if you can, join whatever registries, natural history studies that are around, because that's how we're tracking environmental exposures and looking for common patterns between patients, because it's combining those big data sets in these rare diseases is where we start to see. And then we can start to go backwards and look for causation. But just because you trip over on a path and hit your head, and then you go into the hospital and have a scan and you find a brain tumor, it doesn't mean that the fall caused the brain tumor. It was found at that time. So it's a problem always, with viral infections or pesticide, insecticide exposure. We're going very much on people's recollection of potential exposures, and it's only if people remember. So we're looking for common occupations, anything that people can remember to help us work this out. But it's a very tricky space.
Someone else wondered if immune complex disease could be a trigger to developing IBM.
I'm not sure, Brian, what you mean by immune complex disease. Can you elaborate? That might be a different, we might have a different word for it here.
We can come back to that one.
If you can expand that, I'm happy to try to answer that. IBM, though, is associated with other autoimmune diseases, if that's what you mean, and Sjogren's is probably the most common, but definitely we see other autoimmune diseases with IBM.
Brian added farmer's lung.
Oh, okay. I've never seen an association with those sorts of diseases, farmer's lung, and the deposition of immune complexes. Fair enough. No, I've not seen that association, but as I said, we're constantly seeing new reports of IBM being associated with different autoimmune type diseases. So there's definitely some immune system dysregulation in IBM that makes you more predisposed to developing these sorts of diseases.
The person that had written in about how they had it and her father had IBM, she is concerned about her children. Is there a test for her children, or she just hopes that they have better luck than she does?
That's a great question to look. I think at the moment, if you have any capacity to access genetic testing, and I don't know if you have any DNA from your dad, if he ever had a biopsy, or if you've got an old hairbrush or something, or if he's still alive, you can get DNA from him. But if you could find someone, there are some private genetic companies that doing whole genome sequencing. The problem is it's phishing, really, because you're going to share 50% of the genes with your dad. But it would be looking for, I guess, one of the genes that has been associated with IBM, like the VCP gene. And I guess then if you had it, then when your children became adults, they could decide whether or not they wanted to test for it. The whole issue around pre-symptomatic gene testing is, I guess, for life-threatening type diseases like motor neuron, for example, some people would test pre-symptomatically so that they didn't pass it on to their children. So we can, there are some benefits with regards to that, but with other diseases, some people would choose not to find out if there was nothing we could do to prevent it coming on anyway and just have that hang over their heads. So I don't have a good answer for you, except to say that perhaps it's worth going and seeing a genetic counselor to talk about it. But when there's no gene known, there's probably not much we can do to honestly help guide that risk, because as far as we know, IBM isn't a monogenetic disease unless you have one of those rare ones. And so whether you pursued that, I don't know.
Is there any data on cancer risk for dermatomyositis symptoms starting at age 17 and diagnosis and muscle weakness starting at age 18 for those with the T1F1 antibody? Is there decreased cancer risk for initial symptoms at age 17?
Yeah, that's a great question. So Dr. Oldroyd from the UK has published quite extensively on TIF1 gamma and malignancy risk in DM. And my understanding of what he's written is that if your age of onset is less than 39 years, so from his studies, that you don't have an increased cancer risk with the TIF1 gamma. So it does not in juvenile myositis seem to be associated with cancer. And that's different to the adult onset, but particularly with the age of onset over 39, where there is a very strong association with malignancy. So I think it is quite different. And that's my understanding of the literature, but certainly discuss that with your dermatologist or your neurologist or rheumatologist, but that's my understanding.
Does a patient have a shortened lifespan if they have DM?
That's a great question. I haven't seen any studies to suggest that that's the case. We tried to track that once in IBM. I don't think so. I haven't seen any data to suggest there's a shortened lifespan. But I think, like all diseases with chronic inflammation and chronic immunosuppression, there are some slightly high risks of cardiovascular diseases and other things. So it's, I guess, about being vigilant and monitoring for those sort of longer term complications. But I'm not aware that patients with DM are known to have a shorter lifespan than non-DM or non-myositis patients. But I'm not sure we've really looked at that either. But patients tend to die with DM and not of DM, although some obviously succumb to very severe disease. So I'm not sure about that, to be honest.
Thank you for recommending JAK inhibitors and interferon therapy. If these are available in North Queensland and I took them, would that mean I would be able to wean off prednisone, azathioprine, and methotrexate?
Again, you'd have to talk with your doctor about them. So they're more specific therapies for DM, particularly the skin. And you probably would want to go off at least one of them to go on the JAK inhibitor. The interferon therapy probably isn't available in North Queensland, but the JAK inhibitors we're able to access in Perth through the hospitals on a compassionate basis. Because of the data that's out there now in DM. So I would definitely be talking to your doctor about that, but then looking at the safety of mixing up with your other drugs. But you might be able to access tofacitinib or one of the other JAK inhibitors through the hospital. It wouldn't be available through not easily available through the private sector, I don't think.
Will my IBM eventually cause my body to become contracted as it progresses?
So contractures are often a complication of an imbalance of muscle strength around a joint. So for example, if my it's very hard on this virtual thing. If my biceps are a lot stronger than my triceps, then over time, as they weaken, the stronger muscle starts to win and starts to pull my arm in, and then you can end up with the actual tendon shortened and have contractures. And same with the fingers. The way to avoid contractures as the muscles weaken is to keep stretching and keep moving. So a lot of my patients don't end up with contractures. It's not a key feature that I usually see in IBM, except the patients that really don't move and don't get moved and stretched. So I guess my more socially isolated patients who live alone can end up with some contractures around the fingers and knees, I guess, in particular. But most of my patients don't have contractures with IBM. Just keep moving and keep stretching so that those tendons don't shorten.
My doc says there is no treatment for IBM, but it sounds like you prescribe treatments for it. What treatment should I ask my doc about?
I don't prescribe really medical therapies. Mainly mine are sort of lifestyle interventions. So exercise, sleep, diet, psychology. So that is my standard of care for IBM. I don't prescribe treatments as a regular thing. If pain is an issue, I might prescribe pain meds. Occasionally I'll use very low dose prednisolone. So if pain is a problem in IBM, sometimes patients respond to just 5 of pred, and that's an anti-inflammatory sort of dose. So occasionally I'll use that for pain, not for the disease itself, to get people moving, because I'd much rather have my patients up and moving and not in pain than sitting around being more sedentary with pain. So I'm quite invested in making sure that they're able to move around and function. So yeah, my prescriptions are mainly lifestyle.
I've read that trauma could impact immune systems that results in diseases. Do you think myositis could have a genesis from trauma stress events?
Yeah, look, that's a great question. I think trauma and stress, I think, have a under-recognized impact on the immune system. But there was definitely some reports after 9/11, even of myositis coming on after that. So I think there's no doubt that stress plays a key role in immunity, and I think it's under-recognized, but probably not fully studied either. So yeah, I'd learn some relaxation techniques and stress management techniques to help mitigate that. But you can't turn back the clock, unfortunately. So if you had a very stressful, and life is and can be very stressful, so you can't draw the clock back to sort of untrigger something that was already there, but you must have had a predisposition to develop that, because not everyone who goes through stressful events develops autoimmune disease. So I think you probably need some level of predisposition to developing these diseases, and then something just puts you over, whether that's an infection or a stressful event, just to trigger it. That's the final kind of nail, if you like.
To prevent contracture, if the muscle is too weak to move independently, do you suggest passive movement, such as using someone else to help stretch and keep ROM?
100%. Yeah. Yeah. If you can't move yourself, even laying flat in a bed with gravity excluded, 100%, massage therapies and passive movements will help ease pain and discomfort and prevent contractures, 100%.
Oh, we have 6 minutes left. I thought we were going to make it without a COVID question, but we got one. Is there a link between COVID and myositis, in your opinion?
Look, I think I've definitely seen some cases reported in the literature where someone's had COVID and that's triggered either relapses of known myositis or new diagnosis of myositis. And we've certainly seen that with other autoimmune diseases like myasthenia gravis. I don't think there's necessarily a direct link with the virus itself and the disease, but I think any virus and infection, as I said, anything that can lift your immune system and activate it. And COVID is very inflammatory. It's a very inflammatory virus compared to some of the others. So it really makes your immune system really burst. If you already have that predisposition for developing disease, or you already have the disease and you're sitting close to that threshold, it'll just push you over. So that's my take on it. That's my understanding of the literature as we understand it at the moment.
Okay. Can a documented increase in muscle strength 6 hours after 15 milligrams of prednisone be from reduction in muscle inflammation, or is it more likely an indirect effect of steroids in IBM?
Oh, that's a tough question. I don't know that I can answer that. I mean, I've never seen that reported before. I mean, I don't know whether that would be related to pain or inflammation. 15 is an anti-inflammatory dose, but that's a very quick response. I don't know that I can answer that. I mean, some of my patients 6 hours after would be feeling so good and have more energy and have no pain that they would perform better on strength tests. So I don't know. I think there's lots of reasons why that might be the case. I don't know for sure.
I was diagnosed with dermatomyositis 2 years ago and I'm taking methotrexate. I have tingling feelings in my hands all the time. Is this common? Is it because of methotrexate? Is it a serious issue? What can I or should I do about this?
I would say that tingling feelings in your hands are not common in dermatomyositis. Tingling in hands, though, full stop, is quite common because carpal tunnel is quite common. So I don't know. It would depend on what the distribution of tingling was, or ulnar neuropathies where you compress your ulnar nerve here at the elbow because you rest on your elbow a lot. That's common in IBM in particular because you lose some of that muscle group here and leaves that nerve very exposed there, and you can get tingling particularly in those fingers, whereas carpal tunnel's mainly in those fingers here, around the thumb here. So I would go and see your doctor about that and ask, because no, I don't think I've never seen tingling in fingers as part of DM. I think it's probably something else, and I would go and see your doctor and get them to have a good look at your median and ulnar nerves, and because tingling is usually a nerve symptom and DM doesn't really affect the nerves.
Speaking of nerve symptoms, someone else after prednisone reduction is feeling very stiff. And then also having this feeling like a spider is crawling on her temple. Have you ever heard anything
really
like
common,
that?
I think, as the steroid dose comes down, it's really common for people's pains to come up. So that's, as I wean prednisolone, I always warn patients that they're probably going to get aches and pains. It seems to be a great treatment for osteoarthritis. As for the spider crawling in the upper temple, I'm not sure what that is. Again, that sounds like a very nerve-based problem to have sort of unusual feelings. I guess the other thing it could be would be something weird like a migraine. Again,
without knowing more information,
I'd have to get you to go and see your doctor. I mean, that's a very unusual symptom, and I don't know that it's related to your pred reduction, but the stiffness definitely is, and that's really common. And sometimes you have to alternate. So going from 20 to 15 can be quite a big drop. So sometimes you'll have to go 20, 15 on alternate days for a week or two to get your body used to it before you drop to the 15. Sometimes you have to drop a bit slower and accept that you're just going to get a bit of pain and stiffness and take a bit of Panadol because you definitely want to get that pred down. Yeah.
Do you recommend hot or cold therapies for myositis?
Not specifically. I think it's what works for the patient. So, I mean, cold is sort of, I guess, anti-inflammatory, but warm gets the blood flow going. So I think both have benefit at different times, depending on, if it's pre-exercise, post-exercise. So I don't necessarily recommend one or the other.
We have 4 questions left. Do you have time to go a little bit longer? Are you sure?
Yeah, no worries. Yeah,
I know your day is starting and your family is there.
That's okay. No worries.
But since we were so close to finishing, do you typically wait until normal levels, LDH, aldolase, CK to taper steroids in DM patients?
No, I don't. So, but I always partner steroids in DM with a steroid sparing agent, because the plan is that I start at 50 of steroid and I might leave you at 50 for 4 to 6 weeks, depending on your tolerance of that and how you respond. But the CK can take weeks to months to really drop into normal range. But at the same time, I'll start you on steroid sparer, mycophenolate, methotrexate. And the plan is that will eventually take over from the steroid as the steroid comes down. So I start to wean the steroid as long as the CK is coming down and you are responding, I definitely wean that down after 4 to 6 weeks, because if I leave you on high-dose steroid for too long, you are going to get some really terrible side effects, some of which are worse than the disease itself. So, yep.
Someone found in literature that they shouldn't drink diet sodas. Do you have an opinion?
I don't specifically related to myositis. I would drink more water than sodas. And if you're going to drink soda, I don't know. I haven't seen anything specific about the diet sodas. I noticed that she's referenced that it's in the association literature. So maybe, Rachel, you can comment where that came from.
No, that's why I held that question to last, because I was like, where does it say that? Email me, Rachel@myositis.org, with the link to where we say that, so we can delve into that a little bit further. Is pain associated with IBM? I also have arthritis and assume all my pain is from that, but could part of my chronic pain be caused by the IBM?
Yeah, that's a great question. And I do think IBM is associated with pain, not just due to the arthritis. So I've got some patients that definitely don't have very much arthritis at all and have quite significant pain, really in the muscles, especially the thighs. So I do think IBM can be painful in its own right. And that's what I use the low-dose steroid for, the 5 milligrams, because I think that does help it quite a bit. Or sometimes celecoxib, other sort of gentler anti-inflammatories seem to work with just some simple Panadol. I try to avoid opiates unless absolutely necessary.
This person was diagnosed with Lyme disease in 1985 and then diagnosed with IBM in March of 21. Any thoughts or evidence of a connection between the two?
I've not seen that reported before, but again, we're still exploring this whole sort of genetic susceptibility and environmental triggers. So, I mean, that's a really good one, and that would be great one to sort of record in the registries to see if there's other people that have had, Lyme diseases or Lyme-like diseases that have then, 20 years later gone on to develop IBM. So, yeah, I'm sorry, I have never seen a connection reported before. Yep.
And then finally, what is considered a flare-up?
Is that for IBM, I guess? Some people do report, I guess, that their muscles ache a bit more at times, or their CK might bump up a bit more. And I guess that's what people refer to in the literature as a flare-up. It's not something I see super often in IBM, but some patients definitely report that every now and again their muscles seem to feel a whole lot worse and more painful. And sometimes I can see a slight bump in their CK, and I don't know whether that's a coexistent viral infection. So viral infections often go into muscle. That's why you get the achy sort of muscles with flus and COVID and stuff. So I don't know whether it's that or whether it's the disease itself. And I don't really manage it except symptomatically, usually just helping with the pain and getting you moving again with gentle exercise initially. Yep.
Well, thank you so much for being part of this webinar. We appreciate you sharing your expertise with us. And a lot of people wrote in to say thank you. So wanted to pass that on.
Thanks. Thanks for giving up your time and inviting me to be here. It's great. It's a great initiative by the TMA.
Oh, well, we love it. We love it. We've got it all lined out for next year too. So, and I may be, now that you talked about sleep, I may be contacting you because I want to have an empowerment clinic just on myositis and sleep.
Yeah.
But I haven't found the right physician yet for that.
Okay.
So
I can maybe help with that.
That would be wonderful. All right. Thank you so much for tuning in. Please tune in to the next Ask the Doc series webinar, which airs on Thursday, January 19th from 6 p.m. to 7 p.m. Eastern Time, when we will meet with autoimmune disease specialist, Dr. David Fiorentino. Hope to see you then. For TMA, I am Rachel Bromley. Good night.